Finals SAQ58 near drowning. A 20-year-old man is brought to the emergency department, having been pulled from a river where he got into difficulties while swimming. A. Describe the relevant history and investigations for this patient who had suffered near drowning. Relevant history: victim information, identity, age and gender, medical history, seek possible precipitants for near drowning, such as seizure, syncope, stroke, cardiac pathology such as MI, arrhythmia, long QT, uncontrolled diabetes, hypothermia, consumption of toxins such as drugs and alcohol, associated injuries such as trauma from boat, driving, debris in water or foul play, allergies, information about the scene including timings, duration of submersion, contaminants in water, type of water, ambient and water temperature. Witness accounts are useful. Pre-hospital care including initial ABC, GCS and CPR, time started and any delay. Relevant investigations include core body temperature, capillary blood glucose to assess for poorly controlled diabetes, arterial blood gases, expect hypoxia, hypercapnia and lactic acidosis, venous blood for urea, creatinine kinase, as drowning is associated with myoglobinuria, hypoxemia, hypoperfusion, and hemolysis, which can lead to kidney injury. Electrolyte abnormalities may occur due to fluid shifts, hence assess for electrolyte imbalance. Full blood count and coagulation as DIVC may occur. Toxicology assays for drugs and alcohol. 12-lead ECG, as hypothermia, hypoxia, and acid-base disturbances may lead to arrhythmia and may identify underlying cardiac event. Chest X-ray to assess for ARDS. Transthoracic echo may help optimize CVS management. Trauma imaging as indicated by history and examination, such as CT head and cervical spine. Microbiological investigations such as sputum or tracheal aspirates for culture and sensitivity. This may help with antimicrobial management. B. He has a GCS of 13 but is found to have PaO2 of 45 mmHg, breathing 4 liters of oxygen via a variable performance mask. Outline initial management for this patient. Resuscitation following Resuscitation Council guidelines. Assess airway patency, open airway, prepare for RSI if patient is unable to maintain airway, or patient does not respond rapidly to measures to improve breathing adequacy. Cervical spine control. Breathing. Provide 100% oxygen by non-rebreathing back. Saturation monitoring. Aim to rapidly improve PaO2 as monitored by ABGs. Resolve hypoxia to reduce risk of end organ damage. GCS may improve with increasing PaO2. Move on to pre-oxygenation with tight-fitting mask if insufficient improvement. Chest examination and auscultation may give evidence of associated injuries such as pneumothorax, ARDS, or foreign body inhalation. If PaO2 and GCS not rapidly improving, proceed with RSI, intubation and mechanical ventilation, lung protective ventilation with 6 mL per kg ideal body weight for tidal volume, high PEEP, 100% oxygen initially, then titrate PEEP and FiO2 to achieve target PaO2, ensure P plateau less than 30 cm H2O, avoid permissive hypercapnia in the presence of cerebral edema and raised ICP. Consider orogastric or nasogastric tube to empty the stomach of water and facilitate ventilation. Chest X-ray may demonstrate ARDS and foreign body aspiration. Consider bronchoalveolar lavage. For lung failure resistant to mechanical ventilation, consider ECMO. Corticosteroids are ineffective. Antibiotics should be given if there is evidence of infection. Circulation. Ensure large bore IV access and warm IV fluid resuscitation guided by invasive hemodynamic monitoring. Intravascular depletion occurs due to pulmonary and systemic extravasation. Detection of a pulse may be difficult due to profound vasoconstriction. Arterial cannulation to monitor blood pressure and blood gases. Inotropes or vasopressors may be required. Target MAP of 80 mmHg or above for neuroprotection. Monitor for and manage arrhythmias caused by hypothermia and electrolyte disturbances. Catheterize and monitor urine output as an indicator of end organ perfusion. D. Manage secondary brain injury risk, avoid hypoxemia, maintain low normal capnia, maintain adequate MAP, 80 mmHg or more, maintain glucose 5 to 10 millimoles per liter, warm to 34 degrees Celsius only, with warm fluids, forced air warming, electrical warming pads, etc. Passive rewarming is appropriate for mild hypothermia, but moderate and severe hypothermia will require active external and active internal rewarming respectively. Mild hypothermia should be maintained for 12 to 24 hours. Hyperthermia should be prevented. Fully rewarm if patient is not intubated. Observe for seizures and treat with benzodiazepines as first line. 15 to 20 degree head-up tilt and avoid tight neck tube ties to aid in venous return. Manage coexisting injuries or precipitants. Chairman's report. 57.9% pass rate. Candidates who scored well in Part A of this question presented well-organized answers. Examiners marking this question felt that candidates who scored poorly in Part B did so because they tended to focus solely on airway management and did not mention other important measures in resuscitation, such as rewarming and fluid management. Additional information on drowning. Drowning is defined as respiratory impairment due to submersion or immersion in liquid. It is the second leading cause of unnatural death after road traffic injuries. Drowning occurs in a predominantly healthy and young population and results in significant morbidity and mortality. Primary event is hypoxia due to aspiration of liquid. Degree of physiological derangement is determined by timing of rescue and ranges from no evidence of harm to cardiopulmonary arrest. Secondary pulmonary and neurological injury after cardiac arrest determines patient survival and subsequent quality of life. Risk factors for drowning includes age with peak incidence in toddler age and adolescent age, sex, males more than female, occupation or leisure activities such as fishermen and scuba diving, environmental factors such as access to water, rural areas, warm weather countries and floods, impaired judgment, for example due to alcohol, drugs or hypothermia, medical conditions such as cardiac or neurological disease, trauma and foul play. Outcomes includes death, survival with morbidity or survival without morbidity. Pathophysiology of drowning. Pulmonary aspiration, hypoxia and hypercarbia. Victim's airway lie below surface of a liquid. Voluntary breath holding leads to hypercarbia, hypoxemia and acidosis, which stimulates respiration. Liquid in oropharynx or larynx may lead to laryngospasm. Laryngospasm eventually abates and victim inhales liquid. Pulmonary aspiration, hypoxia, hypercarbia and hypothermia leads to multi-organ dysfunction and failure. Hypothermia is caused by heat loss due to submersion in icy water. Adequate protective hypothermia is unlikely to occur before hypoxia ensues. Pulmonary injury. Fresh water aspiration washes out surfactant, which leads to alveolar collapse and atelectasis. Hypotonic fluid also leads to toxic effects to alveolar and vascular endothelial cells, which leads to interstitial and alveolar edema. Salt water aspiration leads to creation of osmotic gradient and acute alveolar edema. Fluid introduction into airways lead to bronchospasm. Fluctuations in airway pressure with ventilation against closed glottis leads to alveolar rupture and emphysema. Chlorine, pollutants, particulate material, and microbes, when aspirated, leads to pulmonary dysfunction or infection. ARDS may ensue, which leads to VQ mismatch, shunt, and reduced compliance. Cardiovascular effects. Hypoxia, acid-base disturbances, catecholamine surge, and hypothermia leads to arrhythmia, heart failure, cardiac arrest, and SIRS. The diving reflex occurs when apnea, vasoconstriction of non-vital capillary beds, and bradycardia occurs in response to cold water stimulus of the ophthalmic division of the trigeminal nerve. It is protective as blood is redistributed to the heart and brain, and there is reduced myocardial oxygen consumption due to bradycardia. CNS effects. Hypoxia leads to global neurological injury, cerebral edema, and cell death. Degree of neurological injury is determined by water temperature, submersion time, presence of diving reflex, and coexisting CVS and neurological disease. Electrolyte, blood volume, and hematological changes. Drowning in extremely electrolyte-rich liquids may lead to electrolyte abnormalities. Cellular hypoxia leads to lactic acidosis. Aspiration of large fluid volumes can lead to hemolysis, AKI, and DIVC. Renal. Myoglobinuria from muscle injury, lactic acidosis, hypoxemia, and hypoperfusion leads to AKI. Management. This has been discussed in Part B. Studies have shown that the only drowning victims with cardiorespiratory arrest who survived were those who received immediate CPR. Resuscitation should be attempted in all drowning victims, as there are case reports of survivors with initial extreme physiological derangement. The decision to cease resuscitation in drowning victims is complex. Factors associated with prolonged asphyxia includes immersion more than 10 minutes, delay in commencement of CPR more than 10 minutes, and CPR duration more than 25 minutes. Supportive care may be required to manage dysfunction of other organ systems. Associated traumatic injuries and underlying medical conditions should be sought in all patients and managed appropriately. In pediatric patients, child protection issues should be considered. Patients with a GCS of 15, lack of clinical signs of respiratory distress, normal room air oxygen saturations, can be discharged home 4 to 6 hours after emergency department presentation. Thank you.